Hello everyone, I am Dr. Adarsh. Today we will be discussing about trigeminal neuralgia through some case vignettes. Let's see our first case. A 68-year-old woman presents with sudden right-sided facial pain for 3 months. Pain is electric shock-like, lasting around 2 to 3 seconds, and it is triggered by eating, speaking, or touching her right cheek. There is no pain between the episodes. On a neurological examination, she is absolutely fine. So what do you think it would be? The first option is atypical facial pain, which is also known as persistent idiopathic facial pain. As the name suggests, it would be persistent. However, our patient describes an intermittent pain, so this would not be right answer. Third option is temporomandibular joint disorder. TMJ joint pain usually also are aggravated by chewing. They are caused by So the correct diagnosis is trigeminal neuralgia, in which the patient experiences electric shock-like lancetating pain in the cranial nerve fifth territory. Usually it is in the V2 or V3 distribution, and it lasts for seconds. Sometimes it can last for minutes, or it can occur between the episodes also. Some continuous pain can also occur, but predominantly the patient will present with complaints of pain lasting for seconds. The triggers are usually chewing, cold air, or even touching the skin surface can also trigger the pain. How pain-free intervals are usually present between the attacks, and normal neurological examination is there, usually in primary trigeminal neuralgia. If we see the overview of management, the first line drug is carbamazepine or oxcarbamazepine, and if the patient has refractory pain, then we can proceed to surgical modalities. Now let's see a second case. A 34-year-old woman with no relapsing reability multiple sclerosis present with right V2 distribution facial pain, which is electric shock-like quality, triggered by the cold wind, lasting for around seconds. She reports mild numbness over the right cheek. MRI shows a pontine plaque at the trigeminal root. So is this the primary trigeminal neuralgia? What are the odd points in this case? So the first odd point is that she reports mild numbness over the right cheek, which is usually not present in primary trigeminal neuralgia. And the second, there are abnormal MRI findings suggestive of pontine plaque at the trigeminal nerve root. So the first option, that this is a classic primary trigeminal nerve, MS is incidental, it is wrong. This is likely secondary trigeminal neuralgia. The third option, facial numbness rules out trigeminal neuralgia, this is neuropathic pain. This is wrong because the facial numbness can be present in secondary causes of trigeminal neuralgia, and carbamazepine is contraindicated in a multiple sclerosis patient. It can be given for the neuropathic pain. As discussed, this is a secondary trigeminal neuralgia. The MS plaque is the likely etiology. The key points are, we always have to look for the secondary causes. Sensory loss is a red flag but does not exclude trigeminal neuralgia. It can be present in secondary causes like multiple sclerosis, and therefore we should always do MRI to rule out the secondary causes. Carbamazepine is not contraindicated in multiple sclerosis. So the red flags which can point to secondary trigeminal neuralgia are age less than 40, we should do MRI to exclude multiple sclerosis, or cerebropontine angle tumor where the tumor can compress the trigeminal nerve. If the sensory loss is present, then we should look for the secondary causes. Bilateral facial pain, abnormal neurological examination like numbness present in this case, or continuous background pain between the attacks. These are some of the red flags which point out toward the secondary causes. Management in multiple sclerosis related trigeminal neuralgia, carbamazepine is still first line. Multiple sclerosis worsens sodium channel stability, therefore the monitoring of sodium is important. Microvascular decompression is less effective in demyelinating type of trigeminal neuralgia. More of the immunosuppressant and immunomodulatory agents would be more useful. And we have to treat the underlying MS with the disease modifying therapy to reduce relapse frequency. Let us see the third case. A 72-year-old man with confirmed trigeminal neuralgia started on carbamazepine 200 mg twice daily. 6 weeks later, his pain is controlled, but he reports fatigue, confusion, and unsteadiness. Serum sodium is 122, no other comorbidities. So what will you do? First is stop carbamazepine immediately and add phenytoin. Second is switch to oxcarbazepine and correct hyponatremia. Third is reduce carbamazepine dose and monitor sodium closely. And the fourth is add salt tablets and continue carbamazepine unchanged. We can see that the patient is experiencing symptoms of hyponatremia. The serum sodium is 122, and we know carbamazepine can cause SIADH. So in this case, SIADH is a dose-dependent side effect of carbamazepine. We can reduce the carbamazepine dose and monitor sodium closely. If our severe hyponatremia is there, then we may need to stop this drug and use other drugs. So while the patient is on carbamazepine, we have to look for its side effects. One of the most common side effects is SIADH leading to hyponatremia. Second is agranulocytosis. Therefore, we need to check for CBC before and during treatment. It can cause hepatotoxicity. Stevens-Johnson syndrome can be a rare side effect in which we have to stop the drug. And dose-related drowsiness, diplopia, ataxia can occur. Drowsiness is a very common complaint which the patient will present, the patient who is taking carbamazepine. The first line drug in the treatment of trigeminal neuralgia is carbamazepine, and the second is oxcarbazepine. However, we should know that SIADH is a side effect of oxcarbazepine also. The second line drugs are lamotrigine, baclofen, and gabapentin. So if there are side effects of carbamazepine which the patient is not tolerating, like drowsiness, ataxia, then we switch to lamotrigine, baclofen, or gabapentin. And if the patient has refractory trigeminal neuralgia, then we can try intervention approaches like microvascular decompression, in which we surgically remove the artery compressing the trigeminal nerve, usually the superior cerebral artery, which is compressing the trigeminal nerve. Or we can use the gamma knife or balloon compression to damage the nerve so that the pain is reduced. And botulinum toxin A is also being tried, and it has emerging evidence in refractory trigeminal neuralgia. A 55-year-old fit man has had trigeminal neuralgia for 4 years. He failed carbamazepine due to hyponatremia, and oxcarbazepine, he did not feel full relief. MRI confirms right-sided neurovascular contact at cranial nerve 5th root entry zone. He asked about the best long-term fix. So what are the other options when the drugs have failed? Option A is percutaneous balloon decompression. Second is microvascular decompression, which is a surgical procedure. Third is stereotactic radiosurgery using gamma knife. And fourth is glycerol rhizotomy, in which we use a chemical glycerol to partially destroy the trigeminal nerve. So the correct answer is microvascular decompression. It is the only curative procedure, and the patient usually feels 80% pain relief at the 1 year, around 70% at 10 years. The other procedures are destructive procedures. So microvascular decompression, in which we place a Teflon between the vessel and the nerve. Vessel is the superior cerebral artery, which is compressing the trigeminal nerve. It is a non-destructive and it has best outcomes. The other options are gamma knife radiosurgery, in which we use the radio ablation to destroy the trigeminal nerve fiber so that the pain is less. Similarly, balloon compression is done percutaneously. It is also a destructive procedure. Glycerol rhizotomy, we use a chemical glycerol, and in DREZ lesioning, reserved for the refractory cases after all else is failed. So if the patient is young, fit, and neurovascular compression is there on the MRI, then microvascular decompression is the best. However, if the patient is elderly or poor surgical candidate, then we can try gamma knife. Now let's look at an atypical case. A 47-year-old man presents with left V2 trigeminal nerve distribution facial pain. Unlike earlier episodes, pain now persists between attacks. He also notes left-sided hearing loss and intermittent diplopia. MRI brain reveals a posterior fossa lesion at the cerebropontine angle. So there are various red flags in this. First is a pain persisting between the attacks. Second is he has other nerve involvement like left-sided hearing loss and intermittent diplopia. And the MRI showed a posterior fossa lesion. So what would be the correct answer? First is classical trigeminal neuralgia, unusual presentation with atypical features, wrong. Second is acoustic neuroma, vestibular schwannoma at CPA angle, it is a possibility. Third is multiple sclerosis with multiple brainstem plaques. So in the MRI, we did not see any plaques, so this would not be correct. And the third is cluster headache with autonomic features. In this also, the MRI would be normal. So the correct answer is acoustic neuroma. So if the patient is facing continuous background pain and there are other nerve deficits like 8th nerve deficit, we should always suspect cerebropontine angle tumor. And therefore, this case highlights that MRI is important to rule out the secondary causes and mimics of trigeminal neuralgia. So whenever a patient comes with facial pain, we always have to look for the red flags. So continuous or background pain presenting between paroxysm. We should also check for other disorders other than trigeminal neuralgia. If there are ipsilateral cranial nerve deficits like cranial nerve 5th sensory, cranial nerve 8th or cranial nerve 6th, if the cranial nerve 5th sensory is involved, then trigeminal neuropathy can be there. 8th and 6th nerves are involved, then CP angle tumor is there, can be there. If there is bilateral facial pain, we always need to do MRI to look for any demyelinating etiology or bilateral CP angle tumor. If age less than 40 without clear trigger, then we have to rule out demyelinating disorders. Or if there is progressive pain despite adequate drug treatment, if the modalities are not available, MRI is not available, and you started on carbamazepine, however the patient is not responding, then you need to do an MRI to rule out secondary causes and the mimics. So what are the mimics? Acoustic neuroma, meningioma can be there at the clival region, epidermoid cyst can be there, which is the most common benign CPA tumor causing trigeminal neuralgia, secondary trigeminal neuralgia. Aneurysm can be there, which can be compress the cranial nerve 5th. So the management of these conditions would be the neurosurgical referral at first point only.